like to thank the organisers for giving me the opportunity to present these data in a very rare cancer from a very extensive international collaboration. So I'll be talking about a phase 3 comparison between this cyclophosphamide topotecan arm and the high-dose ifosfamide in rEECur, and I present this on behalf of the trial management group, most of whom are named here. So for some background, Ewing sarcoma is a very rare cancer of bone and soft tissues that predominantly affects children and young adults, particularly in the second decade of life. So the incidence rate is 3.2 per million under 25-year-olds. 5-year survival for the disease overall is about 50 to 60%, although there are good and poor prognosis groups within that. For patients where the disease has either progressed on first-line treatment or recurred after treatment, survival is very poor, under 15% at 5 years. And over the years, actually multiple chemotherapy regimens have evolved, and even within those regimens, multiple variations of the dosing schedule. Before we opened the rEECur trial in 2014, the evidence was very poor. There were no randomised trials. There was no consensus on which was the best regimen to treat patients or which we should use as a chemotherapy backbone to test novel agents. So on the top left is the trial design. We initially had a 4-way randomisation and patients could be entered into any 2, 3 or 4 arms depending on their eligibility. It was a multi-arm, multi-stage, adaptive, simultaneous phase 2-3 trial with a Bayesian analysis, and this trial design is an extremely economical way of studying multiple regimens in as few patients as quickly as possible. The primary outcome was event-free survival, and we evaluated multiple secondary outcomes, but the outcomes I will be presenting today are listed here. The drug regimens are shown on the top right. I'm sorry, the formatting has gone a bit wrong for that slide. And the 2 regimens in the phase 3 comparison are in blue. We made a pragmatic decision to drop 2 arms quickly after 50 and 75 patients had been recruited to each arm, however little the difference, based on the primary outcome but taking account of secondary outcomes. And before we opened the study, given that there were really no good evidence at all in this disease, we agreed that if, in the phase 3 comparison, if we showed with 70% probability that one arm was better than the other, that would be adequate to take forward as the standard arm. So showing the primary results, the event-free survival, you can see on the left the survival curve for topotecan cyclophosphamide in blue and for ifosfamide in red. Given the observed data, there was a 96% probability that ifosfamide was better than topocyclo for event-free survival. I should add that the numbers beyond about 6 months are extremely small, so most of the events and therefore most of the analysis was on the left-hand side of the curve. This equated to a 2-month difference in median survival, so 3.5 months for topocyclo and 5.7 months for ifosfamide, and a 10% difference in event-free survival at 6 months. I show here the curve for overall survival. Again, please note the very small numbers beyond about 2 years. So most of the deaths were in the early phase of the survival curve. Again, given the observed data, there was a 94% probability that ifosfamide was better than topotecan cyclophosphamide, and this equated to a 5-month difference in median survival, and again a 10% difference in 1-year overall survival, which was also present at 2 years. So to draw some conclusions, just given the time constraints, I haven't been able to present data on toxicity, etc., but I'll refer to them here. So I'd say again, this is the first ever randomised controlled trial of chemotherapy in this disease setting. It's been a huge collaboration, and in the phase 2 comparison, we showed that ifosfamide was more effective at prolonging EFS and OS than topocyclo. I haven't been able to show it here, but I will present later that the benefits of ifosfamide are more obvious in children under 14. In terms of toxicity, the regimens were similar in terms of the rate of neutropenic infection. Not unexpectedly, ifosfamide caused more renal toxicity and more encephalopathy than topocyclo, with the frequency of those toxicities being less than 10%. We previously showed that the 2 arms that were dropped were unlikely to be more effective than either of the phase 3 arms, but there are still unanswered questions. Importantly, we now have data that we can use both to inform patients, but also to develop future studies. And I should also point out that although we've shown that ifosfamide is better than topocyclo, which is better than irinotecan temozolomide, the differences are quite subtle, and what we actually need is better drugs to cure more patients. Just a very quick acknowledgement to the enormous number of investigators and clinicians who've helped in the trial management group and our funders. Thank you.